Sophisticated trained surgeon. He has boards in plastic and ENT and what else, Mark?
That's enough.
That's enough. And we send him a lot of our NF1 patients here, and so he has an emerging experience.
We've got 7 bottles of water up ready to label mine. I'd like to thank Jeff and Alan and Carol for the invitation to speak to you, and for the challenges that they provide. An MRI or CT scan isn't the thing to do for it. We watch them sometimes. And Jeff had alluded to this. The axons, which are the nerve fibers, pass through the tumor. It is impossible to peel the tumor from the nerve or the nerve from the tumor. They're blended. It's as though you took a wad of gum, stuck it in your hair, and tried to pull the hairs out separately. You cannot do that. You have to kind of do what we call en bloc removal of a segment, at least, of the nerve, or in the analogy of the hair. And so it's really not possible, unlike other tumors, to peel it off the nerve. And it really encases, like the gum does to the hair, it encases the fibers. They're not separable with the retention of function. You can have an intact nerve before it and an intact nerve after it, but missing that segment doesn't allow it to conduct. And they tend to expand axially, as you see in the x-rays, along the nerve. In other words, it's more like a hot dog type of thing rather than just a nodule or a circular type of tumor shape. These are things that you'll read that are supposed to make these difficult for us. I often have to operate on vascular tumors. I don't find them to be highly vascular, or your fear of that should divide whether or not you decide to subject yourself or your kid to an operation. That's really not the same issue that it is with other tumors. Our success is limited by the nature of the tumor. It's infiltrative. It sometimes involves structures that we can't simply remove or replace, and so we have to watch. They tend to recur. If you leave some of it behind that's still alive, that's kind of logical. If it takes 10, 15 years to recur, that's not such a bad deal. We can't do that with malignancies that will have a different time course, and maybe measured in weeks or months if we don't remove it all. There is some correlation with where you have the tumor. The head and neck tends to recur more than other sites, and it's partly because we can't remove things as definitively as we can in a leg or an arm or in a belly. The age, if one has this done in adulthood, there seems to be, again, it's a more mature tumor, and it can be more technically encompassed. Subtotally removing tumors, which emphasized, again, will tend to have a higher incidence of recurrence than one that can be completely removed. So it really depends on what nerve we're dealing with and how expendable that may be. We have a lot of fancy monitors and wires and cables that we can hook you up to, but I will tell you that even with all of them turned up to 10, it cannot predict how a patient is going to wake up and when they're going to regain function and if they're going to get it back. It's an imperfect art, and so we can monitor the heck out of it and have all the technology in the room, and it's still, I find it imperfect, and I always leave a case with some uncertainty about how we're going to end up functioning sometimes. We use microsurgical techniques. We use leaps. Those are the things that you've seen jewelers and watchmakers wear. They magnify our vision. We operate under microscopes. We use instrumentation and sutures that are for this. My world is usually in the 8.0 and 9.0, and this is a human hair running down the middle, so you can see that we're working with very small submillimetric structures to repair nerves and blood vessels and things like that. What we know about how you heal, this is kind of the plastic surgeon speaking, is that the mutation affects the soft tissue ultrastructure. In other words, if you looked at an NF1 soft tissue under the microscope, it's going to look a little bit different than someone who does not have the disease. The skin is often abnormally soft and smooth, and that is good in some places and not good in others. It's felt to be hyperextensible and inelastic, and what that means is we can't simply hike it up or suspend it and expect it to stay there. It's going to change over time, and so those sorts of procedures are not very durable or reliable. And then it does, to a degree, affect the small blood vessels that are a part of the tumor and part of the tissues around the tumor, and so bleeding and things like that, again, are often emphasized in literature, but I do not find that to be prohibitive in any way. And we know that NF patients heal properly, so when we make an incision in you or yours, you're going to end up with a predictable linear scar that's acceptable. So that's an important thing, because there's some diseases that don't allow that or don't do that. There are things that we can do after surgery to restore voice, to restore movement to the face when the facial nerve's involved. We can make one side of the face look like the other side when it's paralyzed, or if it is, and we can use things as simple as Botox, and otherwise we just move other muscles in to move the face. We've heard about the malignant peripheral nerve sheath tumor. One of the biggest difficulties is determining when that happens. We don't have a blood test or a tool or a scan to tell us about that, or tell us when that happens. So it's a clinical, largely clinical diagnosis. We're hoping that PET scans and other things help us do that. But when is a benign tumor growing, say during puberty, childhood, pregnancy, and when is it actually a transformation to a malignant threatening type? Pain along the distribution of the nerve, weakness along the distribution of the nerve, paresthesia is just an abnormal feeling, and there are other signs. Usually peripheral plexiform neurofibromas are not painful. Malignant pain, as Caleb had emphasized, it'll awaken you at night. It never goes away. It is boring at you. It is different. MRI characteristics, PET scans, we hope. And then still, again, as Jeff emphasized, we're learning more and more about how these grow, when they grow. And the more we understand about that, the more we'll understand this transformation process. We're going to skip this because it's been covered. Lifetime risk, as high as 15%, as low as 3% actually. So I think 5 to 10%, which is what you're seeing, is a good number. When we treat a malignant variety, we will sometimes add radiation. Again, we don't use radiation to treat kids because radiation can cause malignant transformation, and it can cause it 2 decades down the road. So we tend to use it only for highly malignant tumors, and you'll hear about maybe stereotactic radiosurgery or gamma knife, particularly on the NF2 side, where highly focused radiation is treating a skull-based tumor that's otherwise not removable. Chemotherapy, when we have nothing else, 5-year survival is not the sort of number you'd like to see. We need to improve that. And then I spoke already to this second primary tumor, which is when we radiate a child, we interfere not only with their growth of their bones, and this could be important in the face, for example, but second primary tumor generation decades down the road. And so this is kind of the construct where we spend a lot of our time reconstructively trying to add nerve grafts where there are segments that have to be removed, or repair nerves that are disrupted in the removal of a tumor. And this is the closing set of points, and it's food for consideration. You'll see it, I think, a lot in the media. In 2006, the first face transplant was done for an NF1 patient in France. And it was presented in 2008 as a part of the first 5 patients who had had face transplants. And it came from that same group in Paris that I had the quote from earlier that said, this sort of thing should be exceptional. And before I show you this, if you have difficulty seeing difficult clinical sorts of pictures, this was their patient. And whether or not that improvement is enough for you to justify the technique is something that a lot of people talk about when they see it in the media. And long-term results of that certainly change over time just as we age. So it remains very controversial. It's experimental. You can't go get this anywhere, and you shouldn't. The risk-to-benefit ratio is very debatable. They're very dangerous. There's a certain mortality to it that's not small. 1 in 5 in that series died perioperatively 2 months later. So just because it's technically feasible for us to do this or offer this doesn't make it the right thing to do. And whether or not it's right for NF or other diseases is very much up for debate. And the allocation of resources is tremendous, where we are talking about limited resources in healthcare and so on. Can we put 6 figures of resource into one person? And again, it's an ethical, it's an economic debate, it's political, it's a lot of things. So again, it will remain in the near future something for very rare and highly selective patients. Long-term immunosuppression can facilitate the conversion of a neurofibroma plexiform to a malignant tumor. So we've got to watch these people for a long period of time to know if this thing even helps them at all. If we get a higher rate of transformation, then we're not helping them. Plan B, if that flap fails, if that lower 2/3 of the face dotted because the blood vessels didn't stay open, you don't have anything else to offer them. There's not a plan B for face transplantation. And then there's a low rate of procurement. It's a very difficult thing to ask a donor to give a kidney, but how about, that part of the bucket. And then, social issues and so on. So a lot of what I speak about is the need for us to assess what we're doing presently and look at where we're going and how to be better at what we do. Thank you.
Lastly, I know we are packing an awful lot into a very short period of time. One last half hour to go, and then we're going to do questions and answers, and also just that you see in your booklet, there's actually a ticket for a lunch when we're done also, so bear with us.